All right. Good morning, everybody. How we doing? Good? All right. Yeah, try to get a little energy around here, I suppose. Let's see. And there's Dr. Swiontkowski. Nice to see you, sir.
Morning.
This is session 2. We're going to talk about peritroch fractures and if they all need a nail. So interesting enough, first session was like talking about things we traditionally would plate and, kind of extreme nailing. These things maybe traditionally we would nail and what the role of plating is. So we'll kind of take it from there. So we have an awesome panel of very seasoned orthopedic traumatologists and people who take care of a lot of these injuries. You have Avi, Ken, and Spence with us in person, and Marc on the good old television with us from Minnesota. So we appreciate everyone's time and energy for this. All disclosures are reconciled in the program, and we'll kind of get over that. So objectives for this, we're going to talk about plating versus nailing. Think about a process of when we nail, when we plate, and understand is there still a role for plating these injuries in 2024? Going to be a little quick didactic, and then we'll get into a bunch of cases to talk about this. So these different types of peritroch fractures, the question becomes, do they all need to be nailed? And I would say that there's debate about this amongst us, and there's literature suggests yes, literature suggests no. So what's the right answer? So traditionally, we're taught of the difference of nailing versus screws for these, peritrochs or intertrochanteric femur fractures is that the nail has a little bit of a shorter lever arm. There's this idea of increased load sharing, and that you have the opportunity that you can span comminution. Well, if that's the case for a nail, is that not the case for a plate? You should ask yourself. The idea of a mechanical advantage of a nail is that it has an intramedullary buttress, right? So it's not dependent on that lateral cortex, which we know can be a bad actor. You have less screw excursion, and as there's new nail designs coming out, less likely for some failure mechanisms, and that you can support that whole zone. But again, you have to ask yourself, if that's true for a nail, is that not true for a plate or some combination thereof? So failure rates, does it matter? So plates, typically the slide and hip screws on these peritrochs or intertrochanteric femur fractures, when they're stable patterns, they shorten, and when they're unstable, they shorten a lot, right? Compared to nails, where they shorten about the same, whether it's stable or unstable. So the take home with this is, when you think about this, is for plating these things, there's a difference with stable and unstable. Nailing, there tends to be no difference in fracture pattern based on the literature. So they talk about classifying implants, right? You hear this a lot, the AOTA classification, which can be a little cumbersome and a little challenging at times. But really, it comes down to, if you just thought about stability, right? So what fracture patterns fall into the stable category, and what fracture patterns fall in the unstable category? And that should help at least guide you a little bit of your thought process of how you're going to take care of these things. So when you think about stability, these are the things very high level of what we think about, right? So stable, they have an intact lateral wall and they're able to be compressed. There's decent bone stock there to be able to do that. Unstable, there's some posterior medial comminution. There's lateral wall incompetency or fracture. There's a specific fracture type of a reverse obliquity, and then subtrochanteric extension. And when you kind of look at this, the traditional thought is like, okay, stable, it's kind of dealer's choice, plate versus nail. Unstable, more or less nail, right? And so that's been kind of the overwhelming thought. So the question should be, is nail ever the wrong answer? Well, maybe not. So old stuff, but evidence-based working group, OTA, looked at these unstable fracture patterns, and they saw that there were better results with nails. Makes sense. And then we've all seen this before, just the demographics of what we as orthopedic surgeons are doing, right? Less plating, more nailing. And is that from a training perspective? Is it because they're really better? Who knows? So again, I asked this question, do they all need to be nailed? Well, what about plating, right? Old literature, but this actually shows that plating with certain constructs, right? When you add something to support that lateral wall, they actually do okay. And in some cases, compared to older nail designs, they actually do better. And then a couple other studies showing that, plating with, again, supporting the lateral cortex for these intertroch protroch fractures actually does okay. So again, I asked the question, do they all need to be nailed? Who knows, right? So we're going to go through a bunch of cases here. And we're going to see what our panel did and would do, and kind of maybe we'll distill down to an answer here, and maybe not. I don't know. Guess we'll see where it takes us. So this is the first case, 87-year-old female, ground level fall. This, I would say, relatively complex proximal femur fracture. So Spence, when you see this, first thoughts?
Well, it's unstable. It's comminuted. The lateral wall looks like it's incompetent. It's a separate fragment. And so, in this particular case, I'm not thinking a hip screw. I'm thinking a nail, and probably not a short nail, probably a long nail because of the subtroch extension.
Yeah, there's a lot of debate about that, short versus long. We can maybe get into that a little bit. Avi, how about you? When you see this, I know you have some preferences here, so I'm just curious what your thoughts are.
I think you can convert this to a, well, you can take care of the lateral wall issue with a trochanter stabilizing plate. I would probably use that and indirectly reduce the fracture by getting my guide pin in axis with the femoral neck, and then add a cannulated screw through the trochanter stabilizing plate.
So far we have 1 vote for nail, 1 vote for plate.
And then be very careful with the shaft reduction. Open and make sure it's axially compressed to minimize the need for sliding of the hip of the screw in the barrel of the plate, which is also blocked to some degree by the trochanter stabilizing plate. But in an unstable pattern, you usually have about 9 millimeters of collapse, but you can minimize that somewhat by axially compressing.
Ken, how about you? Nail versus
And just one more thing, the most important thing in these fractures is getting the rotation right. And I think whether you nail it or plate it, if you don't get the rotation right, the patients are very unhappy. So I will try to get some landmarks for the reduction, which I think you could do well with a open reduction here.
Sure. Ken?
Excuse me. So yeah, I would do nail with ancillary fixation in addition to the nail in the lateral position, and we usually do get a traction view before we go back. With this one, you're going to go lateral on the Jackson table to get that right.
Dr. Swiontkowski from Minnesota, what do you think?
I agree certainly with the lateral position, and I would open it and I would use a nail on this one.
Great. So show of hands in the audience, nail versus plate. Nail? Any platers? No, not many. Okay. This is my case. And, so I chose to nail this. For me, I'm a nailer of things, and this gets a nail. But I think I want to highlight a little bit of what Avi said, is that regardless if you nail or plate this, I think the most important thing is the reduction, right? And so, it's our job as surgeons to get the reduction and then to use whatever implant that we decide to use accordingly to support that, right? And so this, just because we're quote unquote putting a nail in, doesn't mean that there isn't other work that's to be done, right? And so through some strategically placed incisions, there's many different techniques to do this. You can use instruments to support that and to dial in your reduction to make sure that whatever implant that you're using does the appropriate job for you. So here you can see a reduction and some methods to obtain it and maintain it while we're instrumenting the femur, and then ultimately putting our device in. So for me, Spence, similar to you, this I'm more thoughtful about a long nail for this because of the subtrochanteric extension, which has been borne out in the literature. Remember, any fracture lines that go about 3 millimeters or 3 centimeters distal to the lesser have a higher failure rate with short nails. So that's something to consider. And then this is the end result for this 87-year-old who went on to get back to actually a reasonable functional life. So I think, regardless of whether you decide to nail or plate this, I think the take home for this or all of them is that the reduction matters, and it's our job as surgeons to provide that. So,
Can I ask a quick question?
yeah.
And I think we should circle back on it, but two people said lateral position. And my question to the audience, for those people who raise their hands that they nail this, who would feel comfortable doing it in the lateral position? It's worth discussion at some
Yeah, very short.
point. Yeah.
So we got two lateral nailers. Spence, what would you do?
I think for this, with this extension, I would go lateral as well. And I think there are some real benefits that I think people are afraid of lateral position because they're uncomfortable with it. It's unfamiliar, but it has some real advantages. And I'm sure Dr. Swiontkowski could comment on that as well.
Yeah. So I did this actually supine. So,
Yeah.
that's kind of, I think it's whatever. So my take home on that, I think there's pros and cons to both. And I'd be curious about Dr. Swiontkowski's thoughts about lateral nailing. But, I think whatever you feel comfortable and confident in your ability to do the job, I think is important. Dr. Swiontkowski, what do you think? Just cut maybe 30 seconds on your thoughts about lateral position for nailing.
Yeah, I think you were able to do this excellent reduction because it's a relatively thin patient. The bigger the patient, the more important lateral positioning is. You just can't get the optimum starting point in really big patients, supine, reliably anyway. And I believe that everything we've learned about intermedullary nailing stems from Kuncher, and Kuncher was a lateral nailer. So I even nail shaft fractures in the lateral position because it's just so much easier to get the starting point.
Yeah, I think that's an important point. I think for what it's worth from a education perspective and just from a toolbox perspective, you should have that in your toolbox for sure. Have you got?
The greater trochanter is beautifully reduced. Did you use any invisible cerclage on that, or just the clamp and the locking screws captured it?
Yep, that's all. Yeah,
Beautiful.
Just really thoughtful about my reduction and making sure my instrumentation is where I want it to be. Again, this isn't like a, slam a nail down type of situation, right? It's thoughtful and in my opinion, elegant surgery when we do it correctly. All right, so next case. So 32-year-old dental student, multiply injured, has this left subtrochanteric femur fracture with a lot of other injuries as well. So we'll run through some of their injuries, then we'll get to some decision making. So this on the right side, you can see contralateral to that subtrochanteric femur fracture and acetabular fracture. Ipsilateral to that subtrochanteric femur fracture, you can see that femoral neck fracture there, at least on this one, cut. So subtroch with neck extension and then acetabular on the other side. Humerus on the left and an open tibia on the right. So lots of things going on here from a young patient with very high energy, multiply injured patient. So they underwent resuscitation as well as initial fixation of the femoral neck, and then an X-fix to temporize the femur because the patient was unstable, probably for a multitude of reasons. And then, so that's kind of where they're at. And then as things evolved, they have some neurologic issues and the concern for fat emboli, and they're in a kind of a rough spot physiologically. So let's kind of talk about what our thought process is for this fracture. We'll just go down the line. Spence, so a lot going on. I know there's a lot to unpack from a polytrauma perspective, but let's just focus on the femur with the physiology at this point.
Yeah, I mean, obviously, the subtroch fracture, you'd love to get it nailed, and preferably with an antegrade nail. And I think, prior to the medical state the patient's in, I think you could have made an argument for the fact that you could have put screws around that neck fracture and done an antegrade nailing, from the get-go. Now it's a little different situation. The question is neurologic fat emboli syndrome. You don't want to do anything intramedullary if you don't have to, or, if you do, you use a RIA, which is the original reason it was invented in the first place. And you can make an argument for a retrograde nail, and you could use a blocking screw, and there's probably enough of that isthmus there that you could make that work. And, could you just plate that subtroch fracture? I think it depends on, the status of the clearing of the fan emboli syndrome. I think you could do a retrograde nailing and make it stable. I'd be concerned that if I did, I'd probably use a RIA, or all else failed, you could plate it at some point. So yeah, it depends on the patient's medical recovery.
Dr. Swiontkowski, how about you? It's kind
I
of
don't
what
have much. I don't have much to add. What Spence said. He has a ipsilateral humerus, so you could put him in a lateral position and do a plating, and then fix the humerus. That would be a good option. But I also think that retrograde nailing is a reasonable option with the RIA.
Avi?
I agree with retrograde nailing. There's no urgency to do it immediately. Let the fat embolism syndrome clear. You could take out the most distal of those 3 cannulated screws for non-displaced neck fracture. 2 screws is enough. Even a vertical neck fracture, 2 screws is enough if it's non-displaced, which is a very common ipsilateral neck shaft pattern.
Yeah. So Ken, this is your case, Billy. So tell us about your kind of thought process here.
Yeah, excuse me. This is the first time I've seen this neurologic fat emboli, and of course, you get 3 in a row, and then you have your case series. But this didn't clear. Like he was comatose, flat out comatose. Every stimuli you could give him, nothing. Stayed intubated. Finally, neurology said just go ahead. So we looked up anything we could find, and there was 2 cases where they didn't do that great with nails, but they were anecdotal. So their answer at the end of the papers we saw, or the reviews, was it's okay to do the nail. But then that was 2 out of 20. So that's like too high. So we elected to do a plate based on that sparse literature.
How about the tibia?
Same thing.
Plated.
Everything's plated. Yeah.
So here's some intra-op shots of submuscular plating. I think plating a long bone is also a very elegant surgery when done well. And there's definitely some challenges to do that well as well. So I think that's there's probably a lot of technical things here that Ken, you understand that you probably don't think about too much anymore, but this is not that easy of a plating case either. And this is the final construct. So Spence, what do you think?
I think it looks good. It's long. I think, that you could go back to that arguments of working length. I think it's I think it's probably going to do quite well. The only thing that I like to make sure when you can is to get that lateral cortex tensioned and get some immediate load transmission across it because you're plating a subtroch fracture. And I think the difference between having 2 to 3 millimeters of gap, which sometimes you can't even see in the x-ray, versus having it compressed, which only sometimes the surgeon knows is happening, is a big difference in the fatigue life of the construct. But I think it looks good.
Yeah, I like to look at these things as everything's a giant paper clip. At some point, it'll fail if it doesn't heal right. So, and then this is what Ken, you did for the tibia and for the acetabulum, and I think similar thought process, right? Like this guy had such a burden of neurologic deficit from presumed fat emboli that you didn't want to instrument the canals of anything. Yeah.
Yeah, that's right. We didn't want to have any credit points for the lack of recovery, because these patients, they recover like it's crazy. They're comatose for a long time and they just recover. Is the usual course of action for him.
What was the thought that he had like a patent foramen ovale and he had a right to left shunt? And
That was what they came up with. Yeah. Yep.
Yeah, and that
It just took forever to clear.
Any nailing would be risky.
So it sounds like this had a good ultimate story. You had a full recovery and looks like a healed femur. Just out of curiosity's sake, Ken, and your decision to plate this, and I know we're very aggressive about early weight bearing people on nails. Did that change for you at all since you played at this? Like, what
So,
was
so
your,
that's a good question, because honestly, he was making really good callus by the time his brain recovered enough but it would have been a tough question. I think we would have let him weight bear because of the polytrauma.
yeah.
And just kind of see what happened. I think we had enough fixation, would have held up, but we really don't know.
I mean, that's a really strong plate.
It's actually too strong yet.
yeah, exactly.
It's
Yeah,
all we
it-
had.
yeah,
Yeah.
it's
It's pretty robust for sure. Dr. Swiontkowski, just on your thoughts about early weight bearing on a construct like this versus the intramedullary device.
Oh, I think in a patient with this many injuries, that's going to be delayed and getting up and about just as tolerated. Perfect surgery. I commend you. Looks beautiful.
Yeah, I would agree. It's really elegant. All right, we'll go into the next one. So 63-year-old male fall from a deck. This is the only images that we have for this case right now. So, again, question, how many people in the audience would nail this? Okay, any platers? No. All right, Spence?
I think you could go both ways with this. You could do sort of a formal open reduction, internal fixation, and you could use a plate. Given the subtroch extension of that, I think I would nail that. But I would do it. This is definitely one I would do in lateral position, open, and reconstruct, particularly that basicervical fracture, and make sure that's right. And then I would nail it, but it would be an open reduction, lateral position.
Ken, what about you?
Yeah, I would do the same. I would do an open reduction, lateral position, get the neck stabilized separate from the nail. But I'd probably use a recon nail rather than the, big gamma or whatever, or the Synthes nail, or rather than the TFN. I'd
Yeah.
use it.
So a little bit of a
Yeah,
smaller
I
proximal
agree.
diameter.
Yeah, I would
Hmm.
yes, I agree.
Dr. Swiontkowski, what about you? Is this getting a nail in your hands, plate in your hands? And I'm just going to guess that this is going to be a lateral if you're going lateral for this.
Yes, and definitely plate for me.
Definitely plate.
Focus on the neck. It's the most important thing.
As far as plating is concerned, any special considerations on, without naming like brand names, but type of plate? Like, do you use a proximal femoral locking plate? Do you use a long sliding hip screw with a troch stabilization plate? Any considerations?
I think I would use a long sliding hip screw. Fix the neck with a couple of superior screws first, and then put your guide wire in, and then make sure the reduction distally is close enough that you can put screws through the plate to capture it.
Nice. So this is what was done, and obviously your case. So why don't you just kind of tell us your thought process and kind of what kind of went through your head when making this decision?
My greatest concern would be displacing the base of neck fracture and just putting a guide pin in perfectly centered up the axis of the neck. The rest of the operation is done.
Did you use any temporary guide wires or cannulated screws or anything like that to sort of hold that while you put the guide wire up? Because my concern for that is obviously the spinning
it.
Yeah, I mean those other concerns. Yeah.
Um,
Looks like it did very well.
Yeah, I don't recall, this was years ago, but I usually put my finger anteriorly on the neck as I'm tapping and putting the leg screw in. And if I feel it, the head twisting at all, I go back to
Yeah.
2 half turns, advance, third half turn, take it out, tap again. I'm very careful about not spinning the neck.
Well, what if it is spinning on you?
Then I put a second pin in right away.
And do you leave that and change that to a screw then?
I usually in I did this years ago. Usually I'll put a TSP in and put a cannulated screw in through the TSP proximal to the leg screw.
One of the thoughts about or when we nail these things, is the idea of it being biologically friendly and minimally invasive. Like, does this alter that for you? Like, is this a different type of procedure than, say, nailing something? Doesn't matter.
I always remember Jeff Mast article on that shocked everybody with blade plating, these segmentally comminuted femur fractures, and every one of them healed without any infection. And I basically use that concept for this.
What are you, Spence?
I think the question is, if you're going to open this, the question is, what do you do with those subtrochanteric fragments? Do you sort of just get them in position, leave the soft tissue on, and let them make callus, which is what you did here?
Absolutely, yeah.
Or sometimes if you can't position the head neck fragment in space appropriately, then you may choose to reduce them and interfrag them just to allow you to place the proximal segment in correct relationship with the distal segment. And I think that's a nuanced thing that, you have to decide sort of there, if it's helpful or not. And if, do you need some traction sometimes to help you? So to me, that's the challenge, is how to get the neck shaft fragment positioned in space where it needs to be. And sometimes you have to bring like that medial fragment into position to help you.
Mm-hmm. Yeah, I also think, our understanding of bone biology and our ability to do a plating construct like this and still be biologically friendly is very much a real thing. And so just because we're choosing to plate this, and this is what our end construct looks like, doesn't mean that there's a giant biological cost to this as well. So I think, either way, to your point, figuring out if this is what you're doing with that, or you bridging it, or are you going to try to get more of an absolute stable construct and executing your plan accordingly. So I would also say, just like the last one, I think this is a very elegantly done surgery and pretty impressive. So all right, 68-year-old female, or ground level fall, I don't know, male or female, has this left proximal femur fracture. Same question, Ken?
I would get a traction view first.
This is all we have.
Okay.
I think it's a great idea. I wish I could.
No, it's okay. The lady refused, right? She refused. Yeah, we'll get in the OR.
She punched me in the face when I tried to pull her.
Yeah. Yeah. Oh, to be honest, like, it's a nail, but our DHS systems never come up without biocontaminants. So I'm a little bit biased towards the nail.
Can you even find a troch stabilization plate in your hospital?
We've got 3 days.
He's got
3 days. Yeah.
So that's a real thing, though. I think if you are going to plate this, you need to make sure that you have the stuff available to plate. I mean, there's a lot of, we've had this conversation before where people are like, what's a troch and stabilization plate? And they've never seen one. And because they've been taking off all the side hip screw sets. So if you are going to do that, you got to make sure you have it. So I think that could be a limiting factor for sure. Avi, what about you?
You could probably go either way, but if it's a base of neck, again, I think there are more problems with cephalomedullary nails than hip screws for base of neck fractures. They cut through, they don't heal, they cut out. Higher rates with base of neck fractures than other fractures for.
Dr. Swiontkowski, sorry. Dr. Swiontkowski, what about you, nail versus plate for this?
Well, that's just a case to make the point, never go to the OR unless you understand what the fracture pattern is. So, we need more imaging, but I think I would probably lean towards plating, most likely.
So this is what was done, Spence. I think this was your case. So I need to talk us through a little bit of your thought process and, interesting use of a plate here and why, some of the intricacies of this.
Yeah, this is actually my partner's case, because I was searching through my group about some interesting cases. And this is just, personally, I may have plated this as well, just because of it is a pure base of neck fracture. This is sort of a way to protect the lateral wall, to make sure that you are, not breaking it through. This is a channel reamer and then a protection sort of plate laterally, to maintain the integrity of that lateral wall. He ended up nailing it, obviously with this technique, but it's just a way to make sure that you're not violating that lateral wall.
I think the principles remain the same, right?
Yes.
Like whether you're plating this or nailing it, I think you're still, your reduction, you're protecting the lateral wall, like, all those things I think are similar. And
showing the, injecting through the cannulated leg through as well.
Some augmentation, if you will.
Exactly.
Yeah. 40-year-old.
Sorry, it's interesting. The augmentation's on the wrong side. That really doesn't help, but
Yeah.
it's interesting.
I mean, instead of being superior, Mark. Is that?
Correct.
Yeah, okay.
It
Yeah.
doesn't help.
It's where the bone is actually decent in his head, right? No,
Yeah.
it's not good. All right, 40-year-old, again, pretty high energy, left proximal femur fracture. I know it's like a broken record. Nail versus plate, Ken.
That's a nail, lateral position nail. Probably got to open that though and reduce it during the nailing.
So more of an open nailing.
Yeah.
Spence?
I can't, is there a neck component to that, or is that just an inner troch? I mean, I think I'd nail
Looks
this.
like basal cervical neck edge.
Yeah,
I don't know.
I would do it on a fracture table, and, I may probably pass a linear bone clamp across that major fragment line if it didn't behave itself prior to nailing. But yes, this would be a nail on a fracture table, supine position, I think.
Mark, what about you? Nail plate?
I think lateral again, and I would try to nail this. Lateral again because of better starting point, and I would make sure that I've got a fixation across that superior crack before I created a starting point.
I think this is a very challenging nail for that, what you just brought up, Mark. I think, it's easy to start to dig yourself into a hole in this proximal femur when you start putting reamers down there. So I think you need to be very careful and thoughtful about that.
Can I ask Mark a question?
Yeah.
Mark, it's Spence. Are you, how many of these are piriformis start? Are they lateral entry starts? Or because you're lateral, it's obviously easier to get a piriformis start. Are you still using piriformis start nails for certain cases like this?
Yes, that's generally my preference is a piriformis nail. This one, you got to be a little careful. I would have to, this one, I would really look at the CT very hard before figuring out which nail to select. But in general, I favor piriformis start nails because I'm old,
Which is why I'm not.
And again, I will say again, everything we know about nailing is from Guthrie.
I think, since we're in the city of Philadelphia, failing to prepare is preparing to fail, right? Ben Franklin. So I think planning for this is critical. So obviously your case, I mean, I get the sense you're a plater.
Yeah. Again, concerned about displacing the base of neck and trochanteric fragments. Simply put the guide pin in and the operation's over.
And go. Yeah. And then 3 years later, healed, hardware removed, doing okay. Right. Yeah, that's a nice case too. 74-year-old male, fall from standing, these x-rays, Spence.
Not pathologic, I'm assuming.
Nah.
Okay.
I think he fell off a bike.
Yeah. It looks simple.
Mhm.
But again, because I think there's more going on there than actually may meet the eye. I'd like to see what that's going to look like in traction. My first thought would be a nail, but it's a basal cervical fracture. It may be better with a plate. I'm not sure. I think it would base the one to look like in traction.
Yeah. So this is my case. This is what I did. Avi, you done anything different?
Possibly a TSP or possibly a longer plate. Again, there's something that's occurred in our institution in the last couple of years. All of our hip fracture patients are getting admitted to the trauma service, and there's kind of a reflex into the trauma service. They get a chest, abdomen, pelvis CT, and we get to see 3D CTs of all the hip fractures. It's very enlightening, I mean, for a very stable pattern 2-hole DHS is fine, but if there's distal extension or the trochanter is incompetent, or you might be better off with a longer plate or a TSP. But it looks beautiful.
Yeah, so I was happy with this, and so we get him on looping, right? 5 days post-op. So Ken, see this, what do you do
Ah, dang.
other than that?
Yeah, I'll do that. That the only view you have? So the troch's pulling off on you. Is he been mobilized already, walking on it?
Yeah, and he's struggling.
He's struggling. Okay.
Yeah.
So I would convert him to the nail, but I'd usually do more nails. I guess you could think about doing that plate, but I think it'd be really hard to pull that troch down where it belongs with that hunk of metal there and getting it right. I think you get it right with a nail and an ancillary fixation.
Yeah. I mean, the basic construct looks so good. I think I would consider taking out, going to a long 4-hole side plate and putting a troch stabilization plate as a salvage, potentially.
So that's what I did. And I guess the question here is like, but hindsight's always 2020. The lateral wall was probably incompetent and I missed that. And, I probably created an issue as I was putting that in. And so just be really critical about,
Even if it looks competent, if it's very thin and osteopenic,
yeah.
making a big hole in it, sometimes it pays to just throw it on. I try to figure out, why do I love the DHS so much? It was like the first operation I did as an intern, and as interns we were allowed to do them. And nowadays the residents are doing TFNs and gamma nails, and I think there's a certain love affair you develop for the first operation that you do.
And a comfort level.
Well, at our institution, we put a sliding hip screw in. It's like people are like fighting to get into the room.
Yeah.
Yeah.
I mean, it's
Something common.
unbelievable. It's like they want to see it because, oh my God, you're doing a what? We're doing a sliding. Yeah, it's like,
Yeah. So Mark, so it seems like you played a lot of things as well, but what's in your institution, what's your, I would say, breakdown of nailing versus plating these proximal femur fractures? Do you plate more than nail more, or it really depends?
The stable patterns, as you excellently outlined in your initial presentation, the hip screw is equivalent at 1/4 the cost. So in all of our centers in the Twin Cities, the residents are getting good experience with intramedullary nails. Pardon me, with sliding hip screws. And increasingly, I think we need to be more responsible and pay attention to what stuff costs, and it's 25% the cost.
Yeah, I think that's really important. I think as a trainee, it's really important to, again, leave your training program with all the toolboxes possible. So all the tools in your toolbox possible. So we started a little bit late, but we're gonna catch up here. We'll end this session in the next minute or two. We have one more case. I was going to go through it real fast. Spence, I think this is your case, and you can talk a little bit about, what your thoughts were here as we get through it. But this is a person who was nailed 9 months later, comes to see you, obviously not doing well. Avi, in your situation with this, what are you doing at 9 months? So you're taking this person back, you're revising them. I'm just going to make an assumption that you're going to plate this person.
Yes, and I will make sure I kind of, if I can use the same track of the locking screw, diagonal locking screw, for a DHS screw or a super lag screw. There is a 12.5 millimeter standard and a 14 millimeter larger diameter. If I can use the same track and then choose an angle plate, they come in 5-degree increments that will crank it up into a little extra valgus. So you have your automatic indirect valgus intertrochanteric osteotomy to get a non-union healed, and do the best I can on the sagittal plane. Also, it doesn't look bad in the sagittal plane. So just try to crank it up into a little extra valgus. Try to use the same track, and the threaded portion of that locking screw is probably like 10 millimeters. So you still get a great bite there, and you can go in a little bit deeper. So that's my strategy for this.
Can re-nailing this or plating it?
So I would get the young Booth clam, do a little osteotomy and tip them up into valgus, and then I personally would re-nail with the intertan nail.
Okay. So Spence, so this took everything out, and then did this funky crazy thing that
I know, great to talk.
half of us don't know what it is anymore.
I've got all the blade plates and you've got all the choke stabilization plates.
And so this is your end result. So talk us a little bit through like your thought process here and what this device is for those in the audience.
Yeah, I mean, I thought this needed to be tensioned laterally. And it needed to be interfragged because we had now this non-unit is in two pieces essentially, and it's highly oblique, and it's in a little bit of varus. And so I took the screw out and filled that with the bone void filler, and came out with this with a that's a 95-degree device, and that broken screw at the bottom was putting it in. Anyway. Yeah, so that's been tensioned, and it's in, I think, nice position and interfragged, and he's walking and doing relatively well now.
Yeah, I think this is a great salvage, and I don't think we do enough of these and train people how to do enough of these when we need them. So
then we put the articulating tension device on laterally
Tension.
and pulled it down, and yeah, kind of Jeff Mast like sort of, yeah.
So just some takeaways. My personal opinion, and I think the panel would agree, plating is not a lost art. There's very much real and present 2024. I do think classification and really understanding your fracture patterns should guide what you're using. If you're going to really break it down to simplicity, stable, probably go either way, unstable, again, nailing, but you can have these adjuncts that make plating a very real possibility. Blade plate is always a good bailout. And I think that's something that there's a little bit of a lost art that we need to kind of bring back. And then, I think Ken's case really highlighted this, like have all the options in your toolbox, because sometimes you have to change what you would typically do based on the patient's needs. So, before we end up the session, I just, since in my humble opinion, Marc Swiontkowski is one of the giants in orthopedics, I'd like to, if you have any parting words for our participants, that'd be great.
Only related to that last case, we should always be considering bone density when we're planning what we're going to do. In 1984, Reinhold Gantz told me in a similar case that if you're going to pick up a rotten tomato, you pick it up from underneath. So that's why the 95-degree plate is so good, because you're really taking all advantage of every bit of bone density in the femoral head. So outstanding session. Thank you for including me.
Yeah.
Can I say something? Dr. Swiontkowski, correct me if I'm wrong, but I think and the residents here who are starting to use rock more than ortho bullets, they owe it to Dr. Swiontkowski. He's my residents just love the rock.
The rock would be from Tornetta.
I thought you were
No.
project.
No. At JBJS, we have the clinical classroom, which is adaptive learning platform, which is even better, in my opinion.
Oh, okay. We'll move on to that next.
So just in that light, for those of you who don't know in the audience, Dr. Swiontkowski has been the leading force behind JBJS for quite some time now. And so just a true heartfelt thank you from all of us for bringing to the forefront a lot of information that we need that has changed a lot of our practices and being the guiding light there. So thank you for all your service in that and for taking the time out of your very busy schedule to be a part of this.
My pleasure. Thanks for inviting me.
All right. Thanks, everybody.